Okay, so our first guest speaker this afternoon is from the UK. I'm sure he's familiar to many of you, so please welcome Dr. David Oliver, who's going to present to us on when is palliative care appropriate in the care of someone with ALS MND. David.
Thank you very much. I know I won't have hammering to go against, but I'll have gurgling of stomachs and snoring as you all drop off. Thank you very much indeed for the organisers for inviting me to speak today. What I'd like to do is talk about palliative care, as I always do, and where palliative care, I feel, may come into ALS MND. As you know, the WHO definition of palliative care talks about improving quality of life of patients and their families facing problems with life-threatening illness. And I would say that we're looking at ALS MND from diagnosis. And I'd like to say more about that as we go through. But it is looking at prevention, relief of suffering, assessment of pain, and all aspects of care, physical, psychosocial, and spiritual. Now, this has come out of, I'm part of the European Association for Palliative Care, and we've been working with the European Federation of Neurological Societies to look at producing guidelines on neurological care in general, but particularly on ALS MND. And the idea of the guidelines was to encourage a collaboration between neurology and palliative care. The aim was to look at the evidence base, and the overall aim, obviously, is to improve care of patients. So what have we done? We looked at the literature search. There is not a great deal of evidence-based RCT trials on palliative care, let alone palliative care in neurology. So we used experienced clinician group. We tried to come up with recommendations and then support it with some evidence. So what were the sort of recommendations that we came up with? That palliative care should be considered early in the disease trajectory, not just at the end of life, because it can provide ongoing support for patient and family. And I was fascinated hearing this morning the differences that there may be across different cultures, different countries, even different areas within a country, of how palliative care and end-of-life care is seen within neurological services. The assessment of care should be by a multidisciplinary team to give a coordinated approach, that we don't overwhelm patients with what we do, and we support carers. Again, I hope these things are self-evident, but often they don't occur, and I know we've overwhelmed patients within our team by all trying to visit and sort everything out quickly. And I think what's come out, and this is Peter Bede's work in Ireland, looking at how things have changed and how we see palliative care. The top is probably how people saw it in the past, that there would be neurological or medical care, and then just at the end of life, you would have the palliative care input. More and more, there was a feel that there would be an overlap, so that as one got less, the other got more in the middle. But I think I agree with Peter Bede that said, actually, this is episodic involvement. I may have a big involvement at diagnosis with someone saying, what is this awful disease that I've looked up on Google and been frightened about? It may be a gastrostomy at feeding issues, it may be then at ventilatory problems, and then at the end of life. So it's much more this mountainous system where there's coming and going and being more and more involvement. And I think we're all saying within the guidelines, I don't mind whether there's a team led by a neurologist, a palliative care physician, a rehabilitation consultant, whoever, as long as it's a team of people who know about ALS MND and are working together with the patient and family. Because we said that there should be a palliative care assessment. What are the needs of that patient and family? What are the support for other teams? and particularly where there are difficult issues with symptoms, with ethical issues, with psychological issues, and maybe with spiritual issues. Now, spiritual issues may be religious, but they may be those deeper things. I always think of the patient who said, I don't believe in God. I don't think I ever will believe in God. But when my husband became ill, I blamed God. There's that deeper spiritual feelings that are often there, even if they're not expressed in the religious. So there may be quite deep and difficult issues that a team approach would help with. That communication with patients and families should be open, including the setting of goals and therapy options. And again, hearing this morning where there is one country with 15% with tracheostomy, whereas I know if you looked at the UK, it would be less than 1%. And in other countries, it may be much higher. How are those options presented? Does someone say, you can choke to death or have a tracheostomy? That doesn't give a big option. Is it you might have choking problems? Tracheostomy is one way of helping with that. Palliative care and looking at symptom control is another way of looking at that, gives a different option. There may be these decisions about gastrostomy, about ventilatory support, about end-of-life care. And I know there are differences even with end-of-life care. There are some centres in countries where assisted dying is allowed, where many patients may be assisted in their dying. In other countries, people are kept alive with ventilation and fluids and don't even have the opportunity necessary to die. Where is that care taking place? Where is the place of care? Where is the place of death? And those are two different questions. I know I've been caught out because I think I've talked about the place of death, but I've talked about they've heard it as place of care. And when it actually comes to the end, well, yes, we look after him here, but he can't die here. If he dies in this house, we'll have to move. And you think that you've had that communication, but you haven't. So it's those open communication issues. And the planning for care. Is this from the diagnosis? We have no curative treatment, so I would argue we are looking at palliative treatments from diagnosis. Are there decision points with these interventions? Are there crises? Is it just end of life, or is it all of those? And I think we've been arguing very much within the working group that it's looking at all those aspects and helping patients and families talk about those aspects. And we come back to communication. And I think we had fascinating ideas this morning about how communication is so much more than just the iPad. This gentleman, just as a side, was going to Greece for his holidays. So he got an app that said, this does Greek language. So he thought, yes, he'd be able to type in, I would like a beer, and it would then speak that in Greek. It did speak with a very strong Greek accent. And I think it showed the problems of communication. He thought he'd bought one thing, he got something else. The sort of man he is, he now speaks with a Greek accent quite often. He also has in his iPad some quite saucy phrases when the nurses and others come and see him. An important part of communication. We talked about advanced care planning. Do we look at place of care, place of death? Do we talk about that? In the UK, someone can make an advanced statement, which is saying what sort of person they are, what sort of ways they would like decisions made. It can be an advanced decision to refuse treatment, which is actually a binding decision. If someone says, I do not want ventilation, that is binding if it is done under certain circumstances and witnessed. And it becomes someone to put a tracheostomy could, in theory, be prosecuted for assault and battery. We have lasting power of attorney, giving those decisions to others, to a proxy. But probably more important, are we talking about dying? Are we talking with patient, with family, and with professionals? I was fascinated that 37% of the deaths was reported in that one study as being unexpected. I don't think they were all unexpected, really. But had we as professionals been talking about how it was expected, had we been listening to patients and families with their worries and expectations? And in the UK, we have the just-in-case kit, which is discussed with families if they're as appropriate, but medication is provided. The MND Association provide the box. The box is then a source of discussion between patient, family and professionals to say, shall we get some injection medicines available in this house in case there is a problem? Because I find all problems happen on Sunday afternoons. The doctors that know you, the nurses that know you, aren't there on Sunday afternoons. And someone panics. It started because in the UK, someone very high up in the MND Association on a Sunday afternoon was dying. A doctor came and gave them a prescription for amoxicillin capsules for his chest infection. This was someone who couldn't even swallow their own saliva, who died that night very distressed. So it's trying to prepare and think ahead. Recognition of that final stage. Are we looking and saying, this person, we think they are going to die? And I'm afraid often it's our gut feeling. But we try to look at triggers. In the UK, we've looked at triggers of breathlessness and respiratory failure, swallowing issues, cognitive change, weakness, weight loss. And I'm afraid the bottom line, that marked decline in condition, is the doctor or nurse's gut feeling. We've actually started some studies, and someone has looked at a group of patients and found that all those increased as you got nearer to death. And I hope we don't want to extend that study to show that perhaps these triggers are of use. We'll get people thinking. And a proactive assessment of physical, psychosocial issues so we don't need to get to crises. And the principles of symptom management should be applied to neurology patients. We've got a challenge. That carers need to be assessed, was talked about this morning, and also professionals. English doctors cope with stress very well. We have the highest divorce rate, the highest alcohol rate, and a high suicide rate. But we have no problems with stress. So we need to be thinking of the effect on ourselves. And we're also nice, we don't like to think about ourselves. But we need, if we are going to provide good care for patients and families, we need to be looking after ourselves as well. And then finally, we're talking about palliative care principles provided for neurologists, but as important, neurology for palliative care specialists. So it's very much looking at the assessment, the symptoms, positioning, communication issues, the psychological, emotional issues, social and family and spiritual. And at the end of life, ensuring symptoms are controlled, that we're anticipating crises, that we're communicating. Patient as appropriate, family and professionals. The last you want, and we have seen it, is a physiotherapist going in and saying, let's get him up and let's get him stronger, when the rest of the team have said in the previous week, this person is going to die in the next few weeks. It looks as if others have had that experience. So very much looking at symptom control, the support, coordinating that care. And where do we go? hopefully these guidelines will be out very shortly in the new year. We're getting wider application and wider consultation. Looking at palliative care being involved earlier, there will be more collaboration with improved quality of life for patients and families and professional carers. And just to thank the various members of the APC task force and the FNS, and if you want more details or details of when it's going to be published, there's my email. Thank you.
Okay, so your turn now for David. Have you got any questions out there in the audience? Okay,
that
one here
was
at the
too
front.
good, wasn't it?
It was.
Hello, Dr. Oliver. I'm Amy from Wisconsin. I actually had a question for you. You said in an early slide that while it's important that we're multidisciplinary, we should not overwhelm our patients. And I don't know how many times I've seen these families and patients who have sat through 6, 7, 8 disciplines come in, and we try to team up and save questions that way. Do you have any other recommendations for how we can better manage our time so as not to so overwhelm these individuals?
I don't do a big multidisciplinary clinic like that, but we have all our people go to home so that at the end of a week, a family have had 7 people visiting them, a whole group of cards and no chocolate biscuits left. Because they've all had a chocolate biscuit. And I think it's trying to get the discussion as a team to say, this is someone with speech problems and swallowing problems. I don't need to go as a doctor. The speech and language therapist needs to go and will bring me in later. This person is falling. The physio needs to go and can bring us in and can come back and say, I'm not quite sure about this bit. Could you help with that? Can I introduce you to the family later? So I think it's if a team can work together, my always aim in life is that it doesn't matter who's visited the patient, they can come back and say, there's a problem, to one other member of the team and start working together. But it's difficult because we all want to do our own thing and we're all enthusiastic. But I think some families, it's just too much.
Thank you. Okay, in the middle.
Hi, I'm Carolyn Yonk. I'm with the Wisconsin chapter. One of the observations over the years, I've worked with a lot of ALS patients, is when they come back from their initial neurology visit, the neurologist has said to them in one sentence, you have ALS, you're going to need a feeding tube and a ventilator. In the same sentence, go home and put your affairs in order, and they walk out the door. We need to have more compassion and talk about some of the other issues, separate those two out. One is pretty self-sufficient in having that feeding tube. The ventilator is kind of an iffy issue. And so that's always been my bane of contention with that profession and that discipline, is that they need to have a little bit more compassion in how they're presenting that diagnosis.
And I think there's a lot of evidence. We know with cancer patients, in an outpatient clinic, the doctor says you've got cancer. That is the end of any conversation. Nothing is heard after that because and I think the same, ALS, what's that? And you then need to, and the other things are decision processes. Gastrostomy or NIV is a decision process over a period of time. But I know it's difficult for a neurologist who may have this half hour with the patient and think, I'm not going to see them again for 3 months. I've got to get everything in, but we need to have time to take those things on. And I think the diagnosis is enough, let alone all these other things.
Thank you. David, will you join with me in thanking David for his presentation?